Dr. Akash, neonatal multimodal imaging biomarkers in aggressive retinopathy.
A very good afternoon. So my topic is on AROP with anemia and what are the biomarkers to predict success of treatment. I do not have any financial interests. So AROP is an epidemic of the 21st century, India being the most populous country, and 1 in 4 babies in India is a preterm baby. But it's one of the most challenging and most unpredictable disease, and anti-VEGF has proven to be the era for the last decade. And treating AROP is like charting in an ocean where the clinician faces a lot of challenges. So if you have a biomarker, it helps us to navigate easily. So we recently published our first OCT paper where we saw what are the biomarkers which helps us in predicting success for anti-VEGF treatment. And we found out 2 important biomarkers, that is hyperreflectivity of inner retinal layers and choroidal thinning, to be an ischemic biomarker that could predict poor outcomes or more retreatment or more reactivation or more peripheral avascular retina. So here is another example where you can see the eye which had hyperreflectivity and choroidal thinning did poorer compared to the other eye and had early reactivation. Similarly, there was high chance of peripheral avascular retina in ischemic eyes. And another important thing that we noticed in our first OCT paper was anemia was one of the main risk factor that decided, most of these babies were anemic. So this led to a question, what are we missing? So we are just giving anti-VEGF to these eyes. Are we treating only ocular ischemia, or is there anything known as systemic ischemia? So the babies were imaged by a flying baby position where we simultaneously captured fundus photo and OCT by this wide field device. And this gives us an ultra wide field fundus photo as well as simultaneous OCT non-invasively. Here you can see this helps us to image the entire retina. Both multimodal imaging can be done. So what we noticed in our first paper is that we missed on correcting anemia. So we wanted to see if anemia was promptly corrected by blood transfusion in these babies, could that result in a better outcome? So in babies, anemia can be due to immature hematopoietic system. It could be because of anemic mothers, teenage pregnancy, poor antenatal care, postnatal infections, maternal anemia, and all this adds up to systemic ischemia, which is an important factor. So in babies which are having moderate to severe anemia, we also transfused along with giving an anti-VEGF inside the eye. So here you can see how you can see multi-layered hemorrhages, sclerosed vessel. The baby had 6.6 grams of hemoglobin, and we gave anti-VEGF and treated by blood transfusion, dramatic response within a couple of weeks. You can see the vessels opening up and reaching the periphery much more faster. Similarly, here you can see in the above image, there are sclerosed vessels and hemorrhages, and when we gave anti-VEGF and treated the anemia by blood transfusion, dramatic response. All the hemorrhage was gone within a week's time, and the baby was doing much better. Another example where you can see eyes with the hemorrhages and OCT also showing thin choroid and hyperreflectivity of inner retinal layers, suggestive highly ischemic eyes, and not just treating the eye with the anti-VEGF, we treated the systemic ischemia by blood transfusion too, and dramatic response in the inferior images you can see here. So definitely multi-layered hemorrhages and sclerosed vessels and hyperreflectivity of inner retinal layers, which is also seen in other adult vascular diseases. Same way you can see that in aggressive ROP with ischemia and choroidal thinning, which provides nutrition to the outer retinal layers. So what we noticed, here's another image where you can see all these hemorrhages just by giving blood transfusion and anti-VEGF within a week's time showed dramatic response. So what we notice here is in babies, we should not just concentrate on treating the ocular ischemia. Systemic ischemia must be an integral part of the management. Please coordinate with your neonatologist to correct the breathing pattern, the feeding pattern, and also the hemoglobin has to be corrected, or else the high chance of retreatment. Here you can see some of the babies in whom we even, despite of telling the neonatologist, the parental consent was not there, and babies were missed for anemia correction, they had a retreatment of about 70 to 80%, whereas in babies in whom we could manage with blood transfusion promptly, the retreatment rate was 30%. The peripheral avascular retina and reactivation was much lesser. So definitely this demands a treatment guideline change, demands a cultural shift in the way we handle these babies. where we have to treat not just ocular ischemia, but also the systemic ischemia promptly to give a favorable outcome and lesser chances of retreatment and reactivation in these babies. Thank you.
Thank you. There's a earlier paper related with the anemia and the type of ROP.
The first paper was on just predicting the OCT biomarkers in anti-VEGF prognostication of ROP. In that paper, we saw when we took all the systemic factors, most of these babies had severe to moderate anemia, which we did not understand why the OCT biomarkers could have been not just ocular ischemia, but also the underlying systemic ischemia. So in the second paper, we addressed this by prompt correction, and we noticed that these babies had faster vascular progression, lesser chances of retreatment, and lesser chances of reactivation.
Okay,
in any of your babies, when you corrected the anemia by blood transfusion, did you see a transient worsening of ROP? Because we know that the fetal hemoglobin has a better oxygen binding capacity, and when we transfuse with the adult hemoglobin, it sort of gives tissue oxygen, and we see this transient worsening. So what was your the time frame between your injection and the blood transfusion, and did you see any worsening of ROP?
The blood transfusion was immediate within a couple of days in coordination with a neonatologist. None of our babies, we had any inadvertent vitreous hemorrhage or anything. Within 3 weeks, most of our eyes had better opening of loops, and you can see in the images the sclerosed vessels are completely gone, and hemorrhages had, multi-layered hemorrhages had resolved.
Very good images, I must say. Thank you.
Which drug did you inject?
We used bevacizumab, 1/3 of the adult dose.
1/3 of the adult, okay. And what was your criteria for laser? Or was it just a default thing that you did it for all the babies?
Laser, if at all reactivation was seen anywhere during the follow-up, immediate laser was done. Or else, if PAR was noticed at 16th week, that is 4 months, we did the laser, because after that it would be difficult to examine.
16th week, you are counting from the birth. It's not, what is the corrected menstrual age when you
16th week from day of injection.
16 weeks from day of injection.
Yes, yes.
Okay. You did not go by the baby's gestational age or post-menstrual age for calculating the PAR.
16th week from day of injection. The main reason being, after that it is difficult to examine these bigger, heavier babies in OPD.
Yeah. So we do the same thing. Yeah.
The question, in your institution, how many % of patients you are doing laser after anti-VEGF?
So
overall?
In this we can
No,
see
not in this, overall.
30%.
Only 30%. And re-injection?
We do not re-inject. We do not re-inject.
Third question, any systemic complication while doing the test? Comorbidity, tachypnea, systemic destabilization of the children?
We did not have any.
While doing optos?
We did not have any baby with apnea or feed intolerance, but we should take utmost precaution. We have a pediatrician in the same floor where we do this imaging. That precaution has to be taken. And a neonatal resuscitation kit has to be there in the same floor.
Thank you.
Thank you.
Good presentation.